On today's episode, part 2 of my conversation with Alex Murray. Welcome to the podcast helping you overcome your proximal hamstring tendinopathy. This podcast is designed to help you understand this condition, learn the most effective evidence-based treatments, and of course, bust the widespread misconceptions. My name is Brodie Sharpe. I'm an online physiotherapist, recreational athlete, creator of the Run Smarter series, and a chronic proximal hamstring tendinopathy battler. Whether you are an athlete or not, this podcast will educate and empower you in taking the right steps to overcome this horrible condition. So let's give you the right knowledge along with practical takeaways in today's lesson. As you well know by now, last week we did part 1 with Alex Murray talking about why some treatments, why some diagnoses, why some management plans are just different from one PHT client to another. And we continue our conversation. If you haven't listened to part 1, don't know why you'd listen to part 2 straight away, but go back and have a listen to that because we follow on from that quite suddenly. And so here we go. Here's part 2. So when it comes to a treatment path, what should a runner keep in consideration? Should we be asking other people what their pain experience is like or what's worked for them? Or should we just follow a clinician, follow second opinions? What's a good course for that?
I'd probably hijack this a little bit and just say before we jump to treatment, I'd probably just jump on your point about the symptoms matching or not matching a presentation, because Accords Health does spend it has a whole chapter in their book on what they call medically unexplained symptoms, and we're finding that like 50% of the symptoms people see we can't match to a specific condition, or it has so much overlap with other conditions. Like think about a headache. It's a very non-specific symptom. And it's like, well, that could be a brain tumor, or it could be stress, or it could be dehydration. And there's this vast sort of difference. So when we're dealing with symptoms, I always think about heart attack in women. The reason why we don't pick up heart attacks in women a lot more is because when we studied heart attacks, originally we only studied men. And so really a lot of our diagnoses just come from observing lots of people and then sort of trying to spend a lot of time deducing exactly where those symptoms come from. And realistically, there's so many, like we said, overlapping symptoms that it's hard to do that. So a sort of a classic sort of example of this situation is I had a patient come in the other day. Plantar heel pain is what we ended up having, but she had all these neural symptoms exactly like you described. And I was going, whoa, I don't know what's going on. But we scanned her. We found that it was just a really irritated plantar fascia was the main finding. And then we said, well, let's just start treating it like a plantar fascial injury. Let's see what happens. And she got a lot better. But it was good. We ruled out the red flags. We saw some red flags and said, oh, this might be a neural injury. Let's check it out. We stepped through the process. She got better. But it sort of comes from this idea that someone's broken and we need to fix them. And the only way to fix them is a treatment, when realistically, if we start managing someone doing the things that we know we can do and could be helpful, does the body start to sort of sort itself out in a way? Because the body is healing, the body is adaptable. And so I think that's sort of the way I would explain it, is that we can definitely get you into a better place. So can you respond better to other treatments? Do certain things just disappear? So if someone's got plantar fasciitis and they're walking on the outside of their foot and they're developing a peroneal injury, so a tendon on the outside of their foot is starting to get sore, I don't try and treat both. I just say, well, what's the keystone one that we can start with that will then potentially solve the other problems naturally. That's sort of why I sort of look at diagnosis not always being incredibly important, because if we diagnose that person with, a peroneal injury and a plantar fascial injury, they're two completely different treatments or two similar treatments, but it would involve doing a lot more that would make no difference to the person. So that's sort of where we come in.
Yeah, it makes me think of when I was working at clinics, I saw a ton of low back pain. I probably saw maybe 3 or 4 patients a day, new patients with low back pain. And I would have seen thousands in the 8 to 10 years I was working in clinics. And I still had no idea. Like if someone came in with a certain presentation, they had low back pain, and we got them to do certain movements, certain tests, to have a feel around, I would still have no idea how they would respond to treatment based on their pattern of symptoms until I actually started some treatment, started a little bit of treatment, see how they responded, and then did more of that treatment. And it just goes to show there's, like, when it comes, especially around low back pain, there's so many things that could happen. And they've labeled more than 80% of people with low back pain as non-specific low back pain. And it's just a diagnosis that they've decided to label, saying, okay, we don't know exactly what's going on structurally, everything's fine, but they still have back pain. So we'll just label them as non-specific. And this is what we should encourage. We should encourage movement. We should encourage strength. We should reassure them, educate them, avoid bed rest, all this sort of stuff, which is just very, very fluffy, but they get better, but there's no real specific stuff when it comes to a diagnosis. And like you say, when some very common running conditions like patellofemoral pain could overlap or could deviate from its very classic presentation, and then you could have an overlap of two types of things. Maybe it could be ITB syndrome, maybe it could be a combination of things, because everyone's presentation is so different. So rather than the runner feeling like becoming fearful, becoming worried, or being confused with all of these different diagnoses or different presentations, or not fitting a classic thing like they're reading what patellofemoral pain should fit, maybe it's reassuring for them to know that this is normal. It's normal for there to be different symptoms. It's totally normal for there to be not this classic treatment, or maybe not respond to a classic treatment and then just try something else. And as long as they are responding, if they're not responding, try something different. But if they are responding, then be reassured with that and continue along that treatment path. Would you agree?
Yeah. I think that's definitely the case. And I mean, when we look at most studies as well, we average results. I mentioned it before. And so, whenever we do a treatment, there's always going to be 20-30% of people that don't get better or don't get as much better. And we're really bad at communicating that and saying, well, look, there are, people who aren't going to respond. But when we look at, for example, opening up the can of worms that is low back pain, we see people that can respond to yoga. We see people respond to Pilates. We see people respond to strengthening. We see people respond to, very, very specific retraining, core muscles and things. We see all of these things be helpful. So it sort of tells us, well, we get a choice of a lot of the things that we can do. But when we sort of talk about something being non-specific, there is still a specific cause. There is still something specific happening. The issue is what we're identifying by saying it's non-specific is we have no tests or ideas to be able to identify it. But also the fact is that being a non-specific diagnosis means we're also not at risk of having a problem if we miss something. So we know non-specific low back pain, doesn't mean that we have a fracture or something that's going to get worse and they're going to become crippled. We've become very good at identifying those serious pathologies. So being non-specific really means that the field is unfortunately a bit more open, which is a good thing in terms of treatment choice, but it's a bad thing when we find things aren't working for someone because something specific is still happening. And that's where I sort of switch from more of a clinician mode to a coach mode, where the idea is I'm not above the person saying, you need to do this, you need to do that. I'm sort of spending a lot more time coaching people through and saying, okay, if this happened, what do you think we should do? How's this going to fit? How about when we change this? What are you experiencing when we do these movements or these treatments? And we're really just trying to coach someone through. And so having had a patient who, and actually have done some interviews with this patient that are available publicly, who went through this process with patellofemoral pain of seeing all these different clinicians, getting all these different diagnoses, doing all these different things. He was a classic sort of person that didn't fit the mold of the normal responses, was going to everyone, ended up very confused. And really what the biggest difference was having someone who was more of a coach, someone who was going to come alongside him and go, okay, I'm here. We're going to figure this out. I don't know what it is. I don't know what you respond to, but let's create a plan for you. Let's be alongside you. Let's build you back up. Let's figure out what we can do for your life. And so his big thing was rugby. And so he wanted to get back to rugby. So we made a plan and said, well, these are the things that you need to definitely do to get back to rugby. Will they help your knee? Maybe. Will they not? Will they do you any harm? Absolutely not. It's going to help you get towards your goal. And in that sort of process, we went backwards and forwards, and we essentially just built him back up. Now he's playing rugby and he's doing well. But with his experience, I'm still the coach. I'm still going, he still checks in every now and then. He still wants to come in and talk about the experience. And, it's got nothing to do with diagnosis. It's got nothing to do with me having to treat. It's a case of, well, we still don't exactly know what's going on. And it's just become a process of, well, we're going to check in and keep making sure you're on the straight and narrow.
Just listening to Alex talk about that, just wanted me to bring up one particular topic around, I guess, health professionals and therapists being a bit more transparent with the expectations and the response to treatment. And it's very, very hard for a therapist to say that we don't know exactly how you're going to respond and kind of tiptoe around those fine lines. But if they can communicate in a way that says, look, we're not entirely sure how effective this response would be, but at least we're learning along the way. At least we're knowing that what we do may be effective, maybe a little bit effective, maybe ineffective, and then we just reiterate along the way. And I think trying to think of like the opposite example of a therapist saying, you need to do this in order to get better. And then if you do this, and you don't get better, it actually creates a lot of uncertainty, a bit of fear, anxiety about maybe your case is more severe, more different, irresponsive to treatment, and can spark a lot of fear and anxieties. Whereas if that therapist at the start was to communicate in a way that said, all right, if you don't respond to treatment, okay, this is just another test. It's just another thing that we need to do to learn more about your symptoms and reiterate and learn from that response. So talking in absolutes, talking with a lot of confidence that you will get better if you do this, you will get better if you follow 10 shockwave sessions and then implement some strengthening after that. It could be quite tricky and can put a lot of hope. And that kind of language can create a lot of hope and a lot of buy-in initially. But if it doesn't work, then it falls apart, and it can actually be more detrimental than good. And what Alex was talking about when it comes to a coaching approach, I really love that, because when I work with athletes online, I have packages. So I don't just have, just one consult where we jump on a call, I say a couple of things, and then we just leave it there and revisit next week like a standard consult kind of thing. Mine is a package. So either, like in most cases, a month package where we establish a management plan to start with, and then it's just following side by side, day by day throughout the process in case there are fluctuations in symptoms, or in case there are some confusions or lack of clarity around the management plan. We can very frequently communicate back and forth just to make sure that you're clear with everything, and that we're modifying symptoms or modifying exercises based on symptoms and changes and fluctuations and flare-ups and all those unexpected things that might happen. And so that was a really nice take that Alex had, that we may need to start taking on that coaching role, and a therapist that you might be looking for, perhaps try and find someone that is eliciting more of that coaching role and being a little bit more transparent around expectations and their treatment approaches. And so that's a really nice thing to think about, both from the therapist side and from the patient side of things. Feel free to repeat yourself, because I know we've talked about it several times already, but simplistically put, why does someone respond differently to treatment? Why would, if we follow, say, the evidence shows that with people with plantar fasciitis, stretching, strengthening, orthotics helps. Let's follow that with all of our plantar fasciitis patients. Why is treatment so different? Why is the impact so different between people?
So we could look at lots of different things. So it could be the fact that when they do an exercise, they take longer to recover. So we know, and it's more in tendons than in fascia, but we know tendons in some people take up to 72 hours to completely recover from a bout of exercise. Some people as little as 24 hours. So if we're doing a set of exercises and we're doing quite heavy, and then they're doing that in a usual sort of 2 days, so 48 hours after they start again, or maybe only 36, we might not have that time for them to completely have recovered from that previous bout of exercise. They haven't responded, they haven't gotten stronger, and then we're adding more on. So they're in a fatigued state or not a perfect state for them to then benefit from it. So the exercises might actually provide no benefit. There can be factors like if someone is on their feet all day working and moving, that can be a lot of volume and load already. So if we give the same treatment plan of set amount of calf raises at a set intensity, we're adding it on top of load throughout the day. So there's also that other factor of what are they doing throughout the day. There's lots of genetic factors as well in terms of how people respond to injuries. There's a lot of things about, diet and recovery that we don't completely understand. How important that they are need to change, often not. But they may have an impact on why someone responds better than others. There's the sport that people play, the movements that they do. So, it's harder to avoid certain movements in certain sports and activities. It's easier in others. So, when someone is sore, if you are, for example, having a really sore knee and you are playing, rugby, and I keep going back to rugby because it's the sport that I work in at the moment. But if we're thinking, I'm seeing someone in a scrum, they have to be in that position. They have to be loaded in a certain way for their position in the scrum. And so if they continually keep doing that on top of everything else, that may also impact it. Where, other sports and, people might continue to keep playing or might be able to continue to keep running because as they're moving, they're subconsciously able to adjust their gait or their running or their walking or however they're moving to offload that area. That's why we limp. And we can limp unconsciously. So there's lots and lots of things going on. And this is sort of our role as a clinician to try and understand, get this information out of patients and understand it as best we can and put together a picture of why someone may or may not respond. But unfortunately, the short answer is that we don't know. And a big problem is because in the research, we have not embraced this understanding of how the human body works. And we've only really looked at one or two things and excluded everything else, assuming that they're all the same. So, going back to the matchbox example, in the research, we've just focused on the match and the box. We haven't focused on the oxygen, the environment, all the other things that would affect whether that we're actually going to get a lit match and a fire.
This would be a nice segue because I know Cause Health, like you say, they challenge assumptions. And in the past couple of weeks, maybe a couple of months, I've tried to assess my own bias towards treatment and my own limitations. And I think what I've done, especially around this podcast, is focus too heavily on the evidence-based stuff and focus too much on avoiding things that isn't evidence-based. Like if someone comes in and they have pain, they say, I've been foam rolling my ITV, should I continue doing that? I say, well, it's not doing anything. You're better off doing something that's evidence-based. But I recognize that because someone is so individual and we're dealing with the brain, we're dealing with beliefs, we're dealing with any individual unique circumstances, that maybe I'm too fixated, too rigid towards just following the evidence. So one thing that caught my attention when I was listening to you on prior episodes on different podcasts was talking about the limitations around evidence and what, say RCTs, why they're quite limiting. Do you want to maybe just, help broaden my perspective of things and making sure that I'm not just focusing on the pure evidence side of things and why we should be broadening our horizons a little bit?
Yeah. So, we can go down a rabbit hole here, but I can keep it very sort of basic. Because realistically, the foundations of evidence are really basic. If we have a study, essentially what we're doing is, and let's take a randomized controlled trial. This is just a very, very controlled study. So we control a lot of factors. So let's say we take a whole group of runners we split them into two groups, and we make sure that the groups are roughly on average the same amongst a whole bunch of factors. We're assuming that yes, they're all sort of roughly the same. We then give for example, for a trial with a placebo, we're giving one a real treatment and one a placebo, and we see how that treatment goes, and then we compare them. And what we're sort of trying to say is we're looking at and going, well, we got these two groups of runners. They're very, very similar. So we're assuming they're the same. And we're saying these people we gave a treatment, these people we gave a placebo, these people got 50% better, these people got 20% better. So the treatment effect, the specific sort of effect of the treatment is 30%, for example, of that improvement. So we can say, yeah, these people improved more. This treatment is evidence-based, is essentially what we're saying. But the issue is that we're averaging. We're making lots of assumptions. We're saying, well, first of all, these two groups of different runners, we're assuming because they look similar that they are similar on a chemical level, on a tissue level. And we can't say that. And partially because we can't possibly measure every single factor. We're not going to get a blood test on everyone that enters a patellofemoral pain study. We can't control to that level. But the idea was that if we got people that looked the same, it's essentially like being able to have one person come into the clinic and have that exact same person do the treatment and not do the treatment. The other thing is that we average the results, as I've said before. So there's lots of people in the group that would do really well, and there's some people in the group that would do poorly. We've got studies that show that when we break out that average and we actually look at individuals, everyone responds quite differently. So there's a fantastic study that shows that, out of 10 individuals, no one followed the average of no effect. Some people got better, some people got worse, but the average was almost zero. So, we can look at this treatment and go, wow, no one got better from this treatment, but actually a whole bunch of people got better and a whole bunch of people got worse. We just missed that. So when we're talking about things that are evidence-based, we've got to keep in mind that that's what's happening. So for an individual, if they're coming in and saying, I did this treatment and I got worse, that's irrefutable. We can't, often the old view was, but the evidence says people get better with this. So you must have done something wrong. And it's like, no, we know that, if with a lot of treatments, 2-3 out of 10 will not get better. And so we've got to take that information, we've got to look at that and go, well, okay, so what else can we do? And when we're not looking for that one right answer, we've got all of these other answers. We go and we find something that we think may work. Or if we try and understand about and ask questions and work through potentially why that didn't work for them, we can start to be able to guide people better. So from an evidence-based perspective, that's kind of the issue that we have. Those are sort of the assumptions that we're taking in, but also the fact is that we just don't have a lot of evidence. When we look at plantar fascia and strengthening, we actually don't have that much evidence. We have heaps of evidence though for shockwave, because it's really easy to put a shockwave machine on someone and, pound the fascia and then go, did you get better? So there's this lack of information as well. And so there's a great quote by Professor Roger Carey. When I was talking to him, he pretty much just said, you can be evidence-based by just having a systematic process. Being systematic in your thought process is being evidence-based. So if someone comes in and we think about, well, we actually have no evidence for this condition or this person or this setup, what can we do? Well, we just have to be systematic in how we approach, and not and that's where I think a lot of patients go wrong, or not so much they go wrong, but they sort of get directed in the wrong way, is because everyone's sort of going, go here and do this, go here and do that, do this now. And it's this focus on what's that one switch we can flip that will then solve all their problems, when it's a case of, but how are we building this person towards their goals? How is what they're doing what they're given as a treatment, how does that fit with them? How does that fit with their life? How does that fit with the goal of running more or running faster, or just being able to run pain-free? How does that fit in? And what are we doing to their body? Because when we start to just search for that switch flip, we're often then with the treatments just throwing things, throwing spaghetti at the window and seeing what sticks, rather than saying, okay, I have someone that I'm starting to figure out how we're going to get them back running. Great. So what are we going to do? Well, I'm going to give them a strength program because they haven't been running in 4 months, 5 months. They want to get back running. Great. So they need some base level strength. They need to start doing some exercise. Here's some exercises. Will it solve their problem? I don't know. But frankly, they need it for their goal. Let's get them exercising. Let's find exercises they can do comfortably and confidently, and let's start building that. So when we get 2-3 months down the line and we've started to get control of their pain, they're back running, they're building up, we've got this base level of strength that we can call upon. And that's where I see a lot of patients get lost, because they're going from one clinician to another, bouncing, and no one's really going, how am I going to guide this person back? They're sort of just going, I'll solve that problem. I'll try and fix that problem. And that's ultimately probably the thing that we know about the body, is that we don't fix things. The body is adaptable. The body will help fix things itself to a certain degree. And what we're often doing is help guiding the body into a place or an environment or a sort of in sort of a position where it can then heal itself the best. So one sort of other way of looking at it is treatment and management is sometimes just getting out of the body's way of healing. Adjusting the load of how much running someone's doing to essentially then allow the body to do its own thing, and then we start rebuilding, as an example.
Really interesting stuff there. A few things that I wanted to highlight was, first of all, when it comes to pain, I guess not responding to treatment. A bit earlier, Alex was talking about the loading that could go outside of your exercise, or loading that is generated or accumulated outside of, say, your rehab exercises. And this might be one of the factors that means you're not responding to treatment, or not responding to like your stock standard PHT treatment. But then we also need to consider things like diet. We need to consider things like pain, your thoughts. We all know that pain is generated from the brain, and the brain's evaluation of all of its evidence and how it heightens or thinks there is a real or potential threat. That's what creates a lot of that pain. And that topic really rolls on into why sometimes that evidence-based practice relying heavily on that research can fall a bit short, is because a lot of people as an individual, they're producing pain for very different reasons. It might be an actual threat. It might be a potential threat. It might be a catastrophizing approach. You might be really holding a belief that there is a lot of damage going on in that tendon. You may have a general, a real fear that loading that tendon causes more and more damage, sometimes irreversible damage. That's the belief that you had, whether it's true or not. If you have that belief, the brain believes it to be true, and then will produce the pain and produce the heightened threat level and sensitize that whole entire area because of that. And because pain, thoughts, beliefs, all these sort of things, we can't really measure that well. It's something to really consider when we talk about evidence-based practice and, say, the 3 stages of rehab, the 3 stages of loading the tendon, which I've had in earlier episodes. The evidence will follow or put people into groups, follow a particular treatment, follow a particular management plan, and one treatment group will outperform or recover better than another treatment group. And then we say, okay, this is a better treatment for everyone. That's kind of the conclusion that we tend to make, but really it isn't, because it is so multifactorial with beliefs, pain science, all that sort of thing interwoven. Yes, on average, people might get better using that strategy. And as a starting point, we might have confidence in starting off someone with what the evidence shows, but you really shouldn't have any worry or fear if it may get to the situation where you don't respond to evidence-based treatments, because we know it's so multifactorial, and we could say, all right, let's just try a different approach where we are considering a bunch of different factors. And so it's good to think about. It's kind of reassuring to think about if you find that you're not responding to the same treatment plan that someone else may have been dealt in the past. And yeah, it's something that we really need to consider, which is why I love this topic so much. All right, so let's continue with Alex.
Alex, I'm going to try and attempt to summarize this whole conversation and say I'd like your additional comments afterwards. So when we're talking about assessment or like the cause of an injury, once someone is injured, the assessment that is taken and the cause we're only making assumptions in terms of the link of how they got injured. So there could be multiple stories that people tell or multiple opinions from different clinicians because we're just trying to piece that puzzle together. When it comes to a diagnosis, yes, we can have that label for peace of mind or just like a generic kind of template to follow, but there's always going to be some overlap where not everyone will fit a certain thing, or not everyone does fit that certain pattern. We're only just deviating plus or minuses the treatment pattern. So the template plus or minus your individual circumstances. But then when it comes to treatment, it's having that right understanding, having that clinical thinking in mind, but just seeing how the individual responds and then judging the treatment off that. Because we can be evidence-based, we can have the evidence in our mind, but because everyone's so unique and everyone's so individual, let's just try something, see how it goes for a couple of weeks or whatever time frame makes sense. If it's not working, then we need to try something else. If it is working, then we follow more of that or continue that and then add something else in. And then that's how we kind of formulate that management plan. Any additional comments?
No, I think it's a really good summation. I think the thing that I would sort of point out, hearing that all sort of summarize, it sort of makes me think of, these are all very big, broad level ideas. There's lots of specific information that we know. So a good example, patellofemoral pain, you want to do a squat to get people stronger. There is a range of motion where you will put more patellar compression. You'll get more patellar compression and potentially then start to irritate it. So there's lots of bits of information and things that are evidence-based within it that we can use. So it's not all airy-fairy. It's not all very, very fluffy. It's just about how do we get that information and how do we fit it in? Well, it might be a case that, you know, someone can just keep doing squatting and despite that patellar compression, it doesn't irritate them that much. And you're like, great. But there's some people we can use that information and say, actually, you're someone I think we need to adjust your technique and give you a variation of Bulgarian split squat or give you a sissy squat or give you something different to do around that. So yeah, we can be, I think there's lots of very specific knowledge we have. This is broad level knowledge of saying, well, how do we apply that knowledge? So yeah, there's to sort of get out of the fluffiness.
Yeah.
I think in terms of, if I'm thinking about what can a runner do with this information, what can if they're seeing a clinician, what can they take out of this? And I think there's a few things, and it just comes down to asking. And I think the number one sort of one I always ask is, or I always say is, you know, any patient has to get their brand out of a consult. And what brand sort of stands for is benefits, risks, alternatives, and what's the consequences of doing nothing. So if you're going to get a treatment, a clinician should be able to answer what the benefits are of that treatment is, what are the risks of doing it, what's the alternatives that people have. So for a classic example is when people go get cortisone, especially we think like rotator cuff tears, getting cortisone into joints. There are risks. And so what are the alternatives that you have? So you're making a full informed decision, but also what's the benefits or risks or just consequences of doing nothing for a bit and letting the body try and handle itself, because there's lots of conditions that would have a favorable natural history. So an acute flare of low back pain is a classic example. 6 weeks, a lot of what we do doesn't make a huge difference. Our process is really just trying to, at the moment, best way to manage it is just try and keep you active. And then we just set you up and say, well, so the consequences of doing nothing for this acute flare of low back pain, actually, you know, we can just do nothing and it's probably pretty okay. Same with sort of sciatica in its early stages. There's lots of sort of things. So I think asking, you know, getting your brand from out of a consult, but also sort of focusing on your goal and asking a clinician, so this is my goal. How does this treatment fit in? And how am I going to get back to my goal? What other things that could I be doing in addition to this specific treatment for my condition that can help me get back to where I want to be, or get me to where I want to go. So asking those broad sort of questions, because yeah, if your clinician is struggling, then, you know, I don't like to be derogatory or say things, but if, you know, against certain people, but if your clinician is not able to explain these things to you, and you have a very sort of strict goal of, I want to get back to running, or I want to start running faster, then we do have to ask the question of, is that the right clinician for you? It's not saying they're a bad clinician, but it's saying, is that the right clinician for what you are wanting to get out of them? So we think about, in my clinic, we have a number of different patients, and we will internally refer to make sure that patient gets to see the clinician that we think is going to work best for them. And we have a variety of different options as well. So one of the few, sort of podiatry specific clinics that has, a full gym setup. So we have rehab options, we have all these sort of things, and we're trying to match a patient with the treatment and help them reach their goals. And that's how we do it. And so, we do get a lot of patients that come to us that are specific, we can really help them. But at the same time, there's lots of people out there that don't need that and can do very, very well at other clinics with, less stuff, less options, and not this complete understanding of what's going on. And that's perfect as well. But
yeah,
if you're struggling, these are the things that I would ask.
Well, that's perfect. And when you're laying out that brand, the info, I was thinking of people with proximal hamstring tendinopathy. I get a ton of people, and they will often talk whether they should have surgery or not surgery. And it's strange when people just like post on social media, should I get surgery? Should I not get surgery? And you get all these responses back and all these different outcomes. And when it comes down to it, when you talk to your therapist, when you talk to your GP, when you talk to your surgeon, if you just do that, list out that brand, the benefits, risks, alternative, and the cost of doing nothing, what will happen if we do nothing. And if you just lay that out and you get this real candid conversation, you get all the information out there, then you can make that judgment call yourself. And the other thing I'll add on is make sure that you are happy with the response that you get, because you might ask about the benefits or the risks, and a clinician or a surgeon might just rattle off a whole bunch of jargon and a whole bunch of stuff that it just doesn't make sense to you, but you just kind of say, oh yeah, okay. And then just go to your next question. Make sure that you fully understand the response that comes out, because a lot of clinicians are used to talking in like a certain medical jargon that they'll just confuse you, and you just don't want to feel stupid and ask the same question again, or ask to please simplify it. I know a lot of people are shy and just say, well, I asked the question, okay. Just make sure you're really happy with the response, and make sure it's okay just to ask the same question several times until you're happy with the response that you get.
Yeah, 100%. And I think I always sort of think is a good clinician is someone that that's able to explain things incredibly well for someone to understand. Like if people are able to leave and go, yeah, I completely understand it. I've taken this complex topic. I've taken this really I've been reading heaps, but my role is to make it simple for someone to be able to walk away with. And that's sort of where it comes down to that plan. There's all this complexity going on in the background. There's all this crazy stuff that I'm thinking, but ultimately a patient should leave with a plan that makes sense, that's simple, that they can follow step by step. And it doesn't matter. Like I don't have to, I think that's potentially, some of it, may unfortunately be a bit of ego where they want to go, well, I want to show people that I've got this really complex understanding. And it's kind of like, but that's not the job. That's not what patients need. They're not there to be confused. They're there to get a simple, easy to understand plan. And really, if we can take a whole bunch of really complex stuff and make it really simple, that's actually the better sign of intelligence, because it shows that you can understand it, and you can understand it enough that you can make it simple. If it's so complicated that you're not seeing the thread through, do you completely understand it?
And that concludes our discussion. It concludes part 2 with Alex Murray. And I didn't really need to chime in for the back half of that episode, because we were talking about PHT specific stuff anyway. So hopefully you took a lot of benefit around that whole brand acronym to try and come to terms with the best management, the best therapist for you. And I hope this has been enlightening. Hopefully this has been reassuring and left you kind of going away from these 2 parts with a lot of confidence, and just maybe a new plan of attack, a new plan of action when it comes to managing a PHT if things aren't working, or maybe things are working, just not at the pace or at the effectiveness that you might be wanting or expecting. And maybe we can manipulate a few things in here, a few nuances in order for
there to be an increase in treatment effectiveness. And yeah, I hope it sparks some ideas. Maybe it sparks some questions for you to ask your therapist as well, and hope that's delivered a lot of value. And so hope you enjoyed these 2 parts, and we'll catch you next episode. Thanks once again for listening and taking control of your rehab. If you are a runner and love learning through the podcast format, then go ahead and check out the Run Smarter podcast, hosted by me. I'll include the link along with all the other links mentioned today in the show notes. So open up your device, click on the show description, and all the links will be there waiting for you. Congratulations on paving your way forward towards an empowering, pain-free future. And remember, knowledge is power.